Okay, the other day we have looked at hypothyroidism. We are going to look at the hyperthyroidism, a practical approach for diagnosis and treatment. This part we have already seen, how to seed the patient and how to examine and where is the thyroid location and all that last time we have seen. Degradation and yeah, straight away go to the hyperthyroidism. A hypermetabolic biochemical state. Most important, it's a systemic illness. It's not a thyroid illness alone. Because of the hypermetabolism, various tissues in the body produce a hypermetabolic state. It's a multi-system disease. Don't think it is just a thyroid disease. Thyroid hormone has got effect on every end organ, and so naturally it's a multi-system disease. How is it diagnosed? Elevated levels of FT4 and FT3 or both may be there. What is thyrotoxicosis? What is hyperthyroidism? What are the various causes? How to differentiate the causes and how to treat appropriate. Because it's not one entity. Thyrotoxicosis is not one entity. Thyrotoxicosis and hyperthyroidism is slightly different. And there are at least four different types of hyperthyroidism. One needs to understand them, and depending on the cause, the treatment will vary. So the previous slide is important for you. It's a metabolic, biochemical, hypermetabolic biochemical state, multi-system disease, elevated levels of free T4 and free T3. Thyrotoxicosis, hyperthyroidism should be understood. What are the various causes there? How to differentiate the causes? And the treatment is, of course, according to the cause. For hypothyroidism, the treatment is lifelong. For hyperthyroidism, it is not. You understand? You don't have to replace the thyroid. Keep the thyroid, give the antithyroid drugs for lifetime. That's very important for you to know. Graves' disease, diffuse toxic goiter, Plummer's disease, multinodular goiter, toxic multinodular goiter, toxic phase of subacute thyroiditis, also called SAT, SAT, toxic single adenoma, STA. The first four are the primary reasons. Others are secondary. 1 to 4 are primary hyperthyroid. Graves' disease, diffuse toxic goiter, toxic multinodular goiter, or Plummer's disease, toxic phase of SAT, and TSA, that is toxic single adenoma. Primary pituitary tumors produce excess TSH, thereby the gland is whipped with the TSH, and that will be joined here. Okay. So excess TSH from primary pituitary can cause the hyperfunction of the gland. Molar pregnancy, choriocarcinoma, increased beta HCG. There is a lot of similarity between TSH and beta HCG. Beta HCG and TSH, they look alike. The thyroid gland mistakes it for TSH and produces more thyroid. Metastatic thyroid cancers, some usually from the lung or bone, the metastasis will be there. They will be hyperfunction. Struma ovari or dermoid or ovarian tumors. And of course, you should know thyrotoxic fictitia, interferon, amiodarone, SSRI-induced thyroid hyperfunction also, drug-induced hypermetabolic state also you must know. Okay? Now, the most common hyperthyroidism or thyrotoxicosis is Graves. 50 to 60% of hyperthyroidism is Graves' hyperthyroidism. Organ-specific autoimmune disease. That means there are autoantibodies against the thyroid. That means the autoantibody here, it mimics the TSH. And so the thyroid gland thinks the TSH has come and reacts to the autoantibody. Most important antibody is thyroid stimulating immunoglobulin, also called TSI or TSA. It is just like TSH only in all purpose, but it is an autoimmune antibody. TSH acts as a proxy to TSH and stimulates both T3 and T4. Okay. Graves' disease is the most common thyroid. Organ specific, it is an autoimmune disease. Why I am saying that? If you see one autoimmune disease, you must look for other autoimmune. If you see there is no power in this room, you should check immediately the other room. That's what you normally do, isn't it? So most important autoantibody to be examined here is TSA or TSI has to be obtained. TSI, it looks like a proxy to TSH and stimulates the T3, T4. Anti-thyroperoxidase, anti-TPO antibodies, anti-thyroglobulin antibodies, autoimmune diseases like pernicious anemia, type 1 diabetes, and rheumatoid arthritis, myasthenia gravis, vitiligo, and adrenal insufficiency will go along with the Graves' disease. Suppose one has Graves' disease, they may have rheumatoid arthritis, myasthenia gravis, autoimmune vitiligo, and adrenal insufficiency. Other autoimmune disorders like pernicious anemia or type 1 diabetes. The other two antibodies like anti-TPO and anti-thyroglobulin, antimicrosomal also may be positive. But most important antibody is the TSA antibody. So that is the radio scan. You do I-131 or technetium 90. Two isotopes are used here, either I-123 or technetium 99. I-120, what we have to do is ask the patient to swallow one capsule of the radioiodine now, today, in the morning, in empty stomach with good 2 glasses of water. And next morning, after 24 hours, you scan. By then, the radio tracer, iodine will be distributed. Thyroid has got a very good avidity towards iodine, and that iodine uptake will be quantified by the radio scan. That is one method. The other method is if the patient cannot come 2 times, you can ask the patient to have an injection and then wait for 60 minutes. It spreads and then take a scan. Both are acceptable. The absolute contraindication is pregnancy. You should go and come. Okay. So, absolute contraindication, of course, for this test is a pregnant woman. We should not administer. You see on the left side, hand side, you see the normal uptake of the thyroid gland. Thyroid should take up the iodine, but this is the normal uptake. Where you see on the right side, the moment you see it is a hyper functioning uptake, we can easily see by looking at the picture here. This is the next you see. Now I have given you multiple projections. See how densely the thyroid is taken up, right anterior, right LAO, and then different views are taken to see whether the uptake is done. So we have finished one entity. What is the first summary of the first entity? 50 to 60% of the hyperthyroidism is autoimmune Graves' disease. It is an autoimmune disease. Look for other autoimmune diseases also. And here, TSA antibody is predominant. The test for confirmation is FT4 is elevated, FT3 is elevated, TSH is low. You are suspecting hypertension. Refer the patient for radioiodine uptake. Contraindication, pregnancy. I-123 or technetium 99. Both are good isotopes. My personal preference is I-120. They can do technetium also. And here, 2 methods are available, oral as well as IV. Oral is preferable because there is no injection in them. Take a capsule and the patient has to go one more visit, that's all. And then how do the uptake? Normal uptake is there as I have shown you. And the increased uptake is compared, as you can see, very easily pick up the Graves' disease. Then second one is called the TMG or toxic multinodular goiter. Its name itself is suggesting there are multiple nodules. When examination in Graves, when you examine the thyroid, it is diffusely enlarged. There is no localized swelling or anything. A diffuse bilateral, both lobular enlargement is there. Of course, we will see the other clinical features also of Graves. Graves ophthalmopathy, Graves dermopathy, all that will be there. Toxic multinodular goiter is the second most common. Around 20% of the cases are toxic multinodular goiter, more common in the elderly, whereas that one is in the middle age and that one is in females. This is more common in the elderly individuals. It's a long-standing goiter will be there. It is called lumpy, bumpy thyroid. There will be several lumps and bumps in the thyroid. Even undergraduate student will be able to appreciate the multinodular nature. Milder manifestations are apathetic hyperthyroidism. That means hyperthyroid will be very subdued and not very obvious. So toxic multinodular goiter is not very frightening, unlike the Graves' disease. And the hyperthyroidism may be very apathetic or indolent. Mild elevation of the FT3-4 and FT4, T3 and T4. Never do the free total hormones. Always do the free hormone. Progresses slowly over time. Clinically, multiple firm nodules are there. This is also called the plumber's disease. Scintigraphy shows normal areas interspersing with the hot area. The hot nodules will be hot. The normal thyroid tissue will be seen. You can see that. You see. So there is a lot of this. This area is very normal. This is also is mild uptake, hyper uptake, very big uptake. There are 3-4 nodules here. So it's sort of not diffuse, but nodular with areas of normal uptake will be there. Okay. And when you dissect it, it will look like that. The thyroid will have multiple nodules, see around 5 centimeters. 5 centimeters is almost this much. This much size of the thyroid. Okay. The third entity is SAC, subacute thyroiditis. To summarize multinodular goiter is a disease in the elderly. It is equally common in both males and women, whereas in females, Graves is very common. This particular thing is not autoimmune. The thyroid gland is bumpy, lumpy, multiple nodules will be there. Do a radio scan, you see normal area, interspersing with the hyperfunctioning areas. Generally, the hyperthyroidism is on the lower side and not very fulminant or very frightening type of. It is more an apathetic or low. FT4 and FT3 are elevated. TSH is suppressed. The next one is SAT. What is SAT? Subacute thyroid. Here you must understand that what is happening is there is an acute thyroid inflammation due to an autoimmune process. This thyroid inflammation make ruptures open the thyroid vesicles. The vesicles store the thyroid hormone. They release only whenever it is required in small quantities. Because of the inflammation, all the thyroid vesicles rupture and the thyroid hormone is flooded into the system in one shot. And it will subside after 2-3 months. And it will become hypothyroid. What like when all the vesicles are ruptured, no more thyroid, patient will go into hypothyroid. And the treatment here is no antithyroid. Just maintain the anti-inflammatory status with necessary steroids. Painful and tender gland, whereas the other two are painless. Now this is a painful tender gland. Next most common is 15%. T4, T3 are extremely elevated here. The bound hormones are elevated because it is the bound hormone that is there in the vesicle. The vesicles rupture and throw the bound hormones. Here, not only the FT3 and FT4, T3, T4 are elevated. This is how you can easily pick up. Generally, we don't do T3, T4. When we suspect subacute thyroiditis, we can order for T4, T3, bound hormones, and that will be elevated. Immune destruction of thyroid due to a viral infection. Destructive release of the preformed thyroid hormone from the vesicles. Thyroid gland is painful and tender on palpation. If you find a patient with painful neck swelling in the thyroid and a sudden onset of hyperthyroidism, you should think of SAT. Nuclear scintigraphy scan, no RIU in the gland, no radioiodine uptake. because thyroid gland is not hyperfunctioning. Only the infection has caused it to release more. The RAU will be normal. And in fact, we don't require a scintigraphy scan at all. Once we clinically diagnose, if we do it also, it will be normal uptake. Treatment, steroid and NSAID. To relieve the pain and to control the inflammation, anti-inflammatory drugs like NSAIDs and steroid and not anti-thyroid drugs. The condition is self-limiting. It stops after some time. Patient may go in for hypo. Watch for that after 6 months. If hypo, you supplement a little bit of thyroxine. This is the third entity. Now, last one is TSA, toxic single adenoma. That is the one small nodule is there and that is toxic. TSA is a single hyperfunctioning follicular thyroid adenoma. It is a benign tumor of the thyroid, benign monoclonal tumor that usually is larger than 2.5 centimeters. 2.5 centimeters is 1 inch. The usually 5% of the patients who are higher thyroid, 50 to 60%, 20%, 15%, 5%, in the order of decreasing frequency. Nuclear scintigraphy scan shows a solid single hot nodule. TSH is suppressed by the extra thyroid. So the rest of the thyroid gland is suppressed. So this particular thing is throwing the TSH is suppressed. So the one particular area is hyperfunctioning. Because the TSH is reflexly suppressed, feedback inhibition, the rest of the gland will be sleeping. Because this particular thing is secreting more, TSH is not secreted from the pituitary, reflexly stopped, and the rest of the gland will be sleeping. You see? Immediately, very easy. The moment a picture is given, you will show. Now I will show you all the 4 pictures in one go. See, that is, if you, the moment the image is given, you should be able to identify what it is. Normal thyroid, Graves' disease, TMG, toxic single adenoma, SAT, radioadenopathy will be normal. Subacute thyroiditis, radioadenopathy will be normal. This is how the CT scan will be available. Now you see. Age and sex distributions I am giving. Graves' disease, 20 to 40 years. Toxic multinodular goiter, above 50 years. Single toxic adenoma, 35 to 50. Subacute thyroiditis is an infection, so at any time it can come. Sex ratio, Graves 1:5 to 1:10. Toxic multinodular goiter, more common in men compared to Graves' disease, 1:2 to 1:4. Nonetheless, all endocrine diseases are more common in women, particularly thyroid diseases are very common in women. But Graves is 10 times more. If you see a Graves' disease in a man, you have to really think, is it Graves? It's not very common in men, isn't it? The scintigraphy I have. Now, clinical features. What are the clinical features? Clinical features are those that are related to the type of the thyroid toxicosis. Those are specific only to the Graves. Those are those that are related to the hypermetabolic. 3 types of clinical manifestations. The type of thyroid toxicosis producing some clinical features. General Graves' disease specific ophthalmopathy, dermopathy like thing, which are not seen in the other 3 types. And some specific non-specific changes of the hypermetabolism like weight loss, menstrual irregularities and all. Okay. What are the common symptoms? Nervousness, anxiety, increased perspiration, heat intolerance, tremor, hyperactivity, palpitation, weight loss despite increased appetite, reduction in the menstrual flow, or oligomenorrhea. These are the common. This is called warm handshake. When you shake the hands are warm, hypermetabolic, and the sweating also is there, tremor also is there. In anxiety disorder, it's a cold handshake. Cold handshake and warm handshake, we will say. So, increased perspiration because of the excess hypermetabolism, patient cannot tolerate heat, and tremor is there. The type of tremor is a coarse tremor. It means if you ask the patient to keep the hands like that, very coarse. Coarse tremor, you don't require a paper. Whereas when you have a fine tremor, you have to put a paper on that and then it will be brought. That's called Fromet's sign. F-R-O-M-E-T. Fromet's sign means to bring out minor tremor, which is fine tremor. You use put a paper, put off the AC and fan, and then put the paper. Otherwise, fan will be making it flat. So one common mistake is fan is on and paper is fluttering. You will make. Okay. So heat intolerance, tremor, hyperactivity, tachycardia, palpitation, weight loss distress. Sir, I am having voracious appetite last 1 year, but then I am losing weight. So I had a patient who was 80 kilos and he lost about 20 kilos within a matter of 3-4 months. It is impossible to lose weight so fast unless there are 3 or 4 conditions which can produce drastic weight loss. Number one, hyperthyroidism. Number two, underlying malignancy. Number three, uncontrolled diabetes. Number four, psychological disorders. Anorexia nervosa. If a person is losing more than 2 kilograms of weight in 1 month, you have to think of drastic weight loss. In these cases, 6, 7, 8 kilos loss will be there. 4 conditions always remember: hyperthyroidism, underlying malignancy, uncontrolled diabetes, anorexia nervosa. All others will produce subtle weight loss. These are gross weight loss will be there. N number of patients we have diagnosed with this gross weight loss. What are the common signs of hyperthyroid? Hyperactivity, hyperkinesis, tachycardia, poor sinus, atrial arrhythmias may be there. Secondary cause of atrial fibrillation is thyroid. Atrial fibrillation and tachycardia, hyperthyroid. Congestive heart failure because of atrial fibrillation. And systolic hypertension, 100, 200, 150, 180, 190 systolic blood pressure. Diastolic is not. Wide pulse. Okay. Warm, moist, soft, smooth skin called warm handshake. Excessive perspiration, former erythema, onycholysis. I'll show you what is onycholysis. Lid lag and stare. That's due to sympathetic overactivity. Fine tremor of the outstretched hand from its sign. Okay, large muscle weakness. This is myopathy is also very common. Diarrhea may be there. Gynecomastia may be there. One cause of gynecomastia could be thyroid. And one patient I remember, the very first patient, the picture is there, Govindamma. She came to me with diarrhea and the diagnosis of hyperthyroid. Graves. Treated the Graves, diarrhea. Okay. In 2-3 months. Okay. So I told you these are whatever we have discussed in these 2 slides, those that are related to hyperfunction. Now, what are those which are specific to Graves? There are certain features which are specific to Graves. Diffuse, painless, firm enlargement of the thyroid gland. Thyroid bruit is audible with the belly of the stethoscope. Like you put on that carotid in a case of aortic stenosis, you hear the bruit, right? Similarly, on the thyroid gland, you can hear a thyroid bruit. Don't call it as brute, it is called bruit. That's it. Ophthalmopathy, eye manifestations. 50% of the cases of Graves' disease will have eye changes. Sand in the eyes, sort of irritative eyes. Periorbital edema, conjunctival edema is called chemosis, poor lid closure, extraocular muscle dysfunction, diplopia, pain on eye movement, and proptosis. Dermoacropathy, skin and limb manifestations, 20% of the cases. Deposition of glycosaminoglycans in the dermis of the lower leg, non-pitting edema, also called pretibial myxedema. It is not actually, it is a misnomer. It is not myxedema. It is a dermoacropathy due to Graves' disease. Okay. Thickening of the skin over the edema without pain or pruritus. This is called pretibial myxedema. Dermoacropathy in 20%, ophthalmopathy in 50% of the cases. Okay. Use toxic multinodular goit. You see diffuse Graves, diffuse enlargement, multinodular. Okay. And then you see toxic multinodular goiter. You can see one nodule here, one nodule here, one here, another one on this side. And this is the diffuse Graves. Diffuse Graves and toxic multinodular goiter. Again, these are huge toxic multinodular goiters. Grade 4 toxic multinodular goiters. This is proptosis. Proptosis means the eyes will be projecting beyond the palpebral margin, palpebral. Proptosis and lid lag. Lid lag sign is very important. How do you elicit lid lag sign? Ask the patient to look straight first. And then, without tilting the head, ask the patient to look down. When the eyeball moves down, reflexly your lid also will come down. In these people, because the eyeball is bigger, the lid will be lagging the movement of the eyeball. That's called lid lag sign. You see the periorbital edema and chemosis. You can see the swelling of the conjunctiva, periorbital edema and chemosis. And you can see ophthalmopathy. You can see there is a left side sixth nerve palsy is there on this left picture. And you see the picture you see sometimes, the very exophthalmic frightening type of pictures. Okay. Now you see severe exophthalmia is there. What are the causes of exophthalmos other than thyroid? Will be a question. When you get a thyroid short case, they'll ask you. Exophthalmos, you say, what are the causes of exophthalmos? Unilateral exophthalmos, bilateral exophthalmos, orbital deposits, malignancies, the amyloid. These are the other causes of exophthalmos. Then this is the thyroid dermopathy, pink skin and skin-colored papules, and there will be plaques of the skin. This is called pretibial myxedema. It is not myxedema. It is a dermopathy of the thyroid. And then Graves' acropathy. Acropathy means the Graves' goiter is there. For the same patient, you see the acropathy with the clubbing of the fingers and also some sort of contracture-like thing in the. So thyroid acropathy. There will be clubbing and osteoarthropathy may be there. And you see the nails are very much lifted from the nail bed. You can insert a small stick under the nail. That is called onycholysis. Onycholysis, you see, the first part is separated and then it is white in color. It is not pink. So the attached part is pink. This part is not attached to the underlying soft tissue. So much so it is lifted up. And you can, in fact, without pain, you can introduce a small thing under. This is called onycholysis. One cause of onycholysis is hyperthyroidism. Usual cause of onycholysis is tinea angum. Tinea angum is a common cause, but this is one other cause of it. Okay. And now we have discussed those which are general, those which are specific to the Graves' disease, those which have non-specific changes, we are going to discuss. Non-specific metabolic changes. Hypermetabolism produces hyperglycemia, glycosuria, secondary diabetes mellitus, osteoporosis, hypercalcemia, low LDL, hypothyroidism, high LDL, hyperthyroidism, low LDL, total cholesterol also low, atrial fibrillation, left ventricular hypertrophy, left ventricular ejection fraction is increased. Normally, it should be around 50 to 60%. This fellow, because of forceful contraction, he will get 70% ejection fraction. That is higher. And then hyperdynamic circulatory state, that means you have wide pulse pressure, tachycardia, high output heart failure, a history of excess iodine, amiodarone, or contrast dyes may also be there. Now, last time we have seen that is primary hyperthyroidism, where the thyroxine will be very high, FT4 and TSH will be very low. The box will be that. That is subclinical hyperthyroidism. And then you have got the diagnosis. How do I diagnose it? Typical clinical presentation, if you have the eye, unmistakable, markedly suppressed TSH, maybe 0 also sometimes, or less than 0.05, elevated FT4 and FT3, markedly elevated in Graves, thyroid antibodies, anti-TPO and TSI antibodies particularly, ECG to demonstrate atrial fibrillation, tachycardia, left ventricular enlargement, and the echo shows, a hyperdynamic heart with increased ejection fraction. Scintigraphy, of course, to differentiate the causes. Okay. Now, algorithmic approach for the hyperthyroid. Patient has come. I have to one by one, step by step, go forward. How? Measure TSH and FT4. Whereas in hypo, he measured only TSH. Here, when we are suspecting hyperfunction, measure TSH as well as FT4. Because hyperfunctioning will require the hormone also. Both normal TSH, FT4 also is normal. Most of the individuals it will be like that. Then then you have to do a nuclear scan and FNAs because there is a swelling. The swelling TSH4 is normal, FT4 is normal. It is not hyperfunctioning. Then it could be malignant nodule or it could be any other condition. There may be benign autoimmune enlargement or it could be related. Do an FNAC and nuclear scan. If the thyroid function is normal, TSH and FT4, and if you detect a swelling in the thyroid, you are bound to do an FNAC and normal and nuclear scan. TSH is decreased, FT4 is very much elevated. I am dealing with hyperfunction now. Now I have to differentiate the four types. One is the Graves, other is the Plummett's disease, multinodular goiter. Third one is subacute thyroiditis. Fourth one is the singular toxic adenoma. I have to differentiate. So primary thyrotoxicosis because TSH is low and FT4. Secondary means TSH is also elevated, FT4 also is elevated. The stimulation is coming from above. That is why the gland is hyper. Gland per se is not at fault. Somebody, the master, is telling it to secrete. That is secondary. Primary thyrotoxicosis. Features of Graves present. What are the features of Graves? Ophthalmopathy, then chemosis, and the lid lag, and then the periorbital edema, ophthalmopathy, there may be ophthalmoplegia, and then proptosis. Along with tremor, tachycardia, hyperfunctioning, and all the acropathy may be there, dermopathy also may be there. These features are there. It is Graves. How do I confirm? Yes, you do a treatment for Graves immediately. And if you do an antibody, TSA antibody will be very much elevated. Don't forget to look for other autoimmune diseases. Okay. Features of Graves' disease are not there. That means I am left with three other conditions: MNG, TSA, STA. Okay. Now I do the radioiodine. Even Graves also you can do a radioiodine and confirm. The clinical features are so clear cut. Radioiodine testing will be a diffuse uptake will be there. It is a redundant test. But if you do it also, nothing. Increase the radioiodine uptake. Okay. Increase radioiodine uptake in only two conditions: single toxic adenoma and then multinodular. In the SCAT, it is normal. So, if the radioiodine is elevated, if there are hyperfunctioning, hyperthyroidism is there, features of Graves' disease are absent, I am dealing with adenoma and MNG. Okay, there is no increase in the radioiodine uptake, low radioiodine uptake is there, or normal radioiodine uptake, subacute thyroiditis, iodine deficiency, iodine related goiter, or excessive thyroxine administration by the doctor. So suppose you go on giving the thyroxine for 6 months, there will be features of Graves, not Graves, hyperthyroid. Features of hyperthyroidism, radioiodine will be because secondary suppression of this one. Now, TSH is low, but FT4 is normal. This is called subclinical hypothyroidism. Then, or it could be T3 toxicosis. TSH is suppressed. That means there must be toxicosis, but my FT4 is normal. So there could be a condition called T3 toxicosis. Then measure the FT3, and if it is very high, you are dealing with T3 toxicosis. Supposing it is normal, FT3 is also normal, then you are dealing with the subclinical high. Okay? Patient has come with features of some thyroid swelling and suspected hyper. First thing what I do FT4 and TSH. If both are normal, then swelling is there, maybe malignant, maybe iodine related, do an FNS nucleus. Algorithm, we left the algorithm. Suppose TSH is lower and FT4 is higher, that means it is a primary from the thyroid. Pituitary is all right, thyroid is producing more TSH, that is why feedback inhibition. The thyroid is producing more thyroxine, so feedback inhibition of the TSH. In such case, it is primary thyroid. Look for features of Graves. Features of Graves present, may or may not do RIA, straight away you can treat it. If the features of Graves are absent, then you are compelled to do the RIA to differentiate whether it is single toxic adenoma or multinodular. Radioiodine uptake will be invariably elevated in single toxic adenoma and multinodular. Picture is very distinct. One will have a crisp single nodule, the other will have multiple nodules with in-between spaces also. Maybe not. If the radioiodine uptake is low and it is acute, subacute thyroiditis or iodine excess or due to iodine deficiency or due to the excessive thyroxine. Then, if the TSH is suppressed already, FT is not elevated. I am left with two conditions. One could be subclinical, the other could be T3 toxicosis. Do a T3. If T3 is elevated, it is T3 toxic. T3 is normal, but still you have FT4, T3 normal, TSH is low. It is a subclinical hyperthyroid. Okay. Now, what do I do for subclinical hyperthyroid? Follow up in 6 to 12. You don't have to do any treatment. Subclinical will become clinical. Once it becomes clinical, then you classify into the 4 diseases and then start. So follow up after 6 to 12. Now, one more is there. TSH is elevated. FT4 also is elevated. That means what? That is secondary hyperthyroid. Okay? Pituitary adenoma is the cause. So look for the MRI of the pituitary adenoma, treat the adenoma automatically, secondary. This is the algorithm. All of you must know these are international algorithm. Okay? Sorry, I am not. So now you can see the algorithm. Okay? How do you go? Now, I have to treat them. Once I know the diagnosis, I have to treat. Symptom relief medications. Tremor, hyperactivity, loss of weight, looks ferocious, anger, sweating, perspiration, that should be controlled. So obviously you require symptom relief medication. Second one is ATD, anti-thyroid drugs. There are 2 groups of drugs available. The imidazole group, that is the methimazole and carbimazole, and the propyl thiazide. PTU, methimazole carbimazole group, and propyl thiazide. 2 antithyroid drugs are available. Radioactive iodine treatment is available. Thyroidectomy is a possibility, and NSAIDs and corticosteroids for the subacute thyroid. These are the things we have. Very simple. So symptom relief medications, rehydration is the first step. Thyroid patient loses a lot of because of excessive heat, hypermetabolism, perspiration, tachycardia, hyperdynamic circulation. He will be losing a lot of water and he must have enough hydration. Beta blockers to decrease the sympathetic axis. Propranolol is the ideal drug. It is available in the release for sustained release formulation. Propranolol SR is available. So you can give once a day, you don't have to take. Otherwise, ordinary propranolol, Inderol, or these things you have to give 3 times a day. So really sustained release formulation, CR or SR, controlled release once a day. Atenolol and metoprolol can also be substituted. The preferable drug is propranolol. Rate limiting calcium channel blockers if beta blockers are contraindicated. What are rate limiting calcium channel blockers? Rate increasing calcium channel blocker is your nifedipine group of drugs. Rate limiting ones are verapamil. Verapamil type of drug you have to use. Okay, treatment for CHF, treatment for arrhythmias, calcium supplementation must be there because a lot of calcium is withdrawn from the bone. SSKI or Lugol saturated solution of potassium iodide. SSKI is saturated solution of Ki. Ki is potassium iodide or Lugol solution to decrease the vascularity of the gland. I will tell a little bit about that a little later. Now, what are the anti-thyroid drugs? So there are two groups of drugs, either carbamazole or methimazole. There's nothing to choose between them. Methimazole is as good as carbamazole, and propylthiouracil is the other group of drugs. Efficacy, very potent. Methimazole, propylthiouracil is potent. Duration of action, long acting, give once in a day, whereas the short acting propylthiouracil, you have to give 3 or 4 times a day. Pregnancy, methimazole is contraindicated. Propylthiouracil can be safely given. Pregnant women, hyperthyroid, you want to treat with a drug, don't put them on neomercazole. Neomercazole is carbamazole, or methimazole. Don't put the propylthiouracil because methimazole is contraindicated. Neomercazole, methimazole, carbamazole is contraindicated in pregnancy. So iodination and coupling are interfered by methimazole. Have the same mechanism in the propylthiouracil. Conversion of T4 to T3, there is no action, whereas that one is inhibits the conversion. That is why it is a short acting. Adverse reactions, most important adverse reaction when you put them on antithyroid drug is neutropenia and then sepsis. So all the patient have CBC every 1 month, and the moment they report a sore throat, you stop the drug and then treat with antibiotic. Neutropenia and then streptococcal sore throat is a problem. Rashes can occur. What is the dose? Available as 10 milligram tablets. You can give 20 to 40 milligrams once in a day per oral. Methimazole, propylthiouracil available as 100 milligram capsules. You can use 100 to 150 milligrams 4 times a day per oral. These are the difference between methimazole. Then, question is how long I give antithyroid? As I told you, hypothyroidism lifelong, hyperthyroidism only limited duration. Reduction of thyroid hormones takes 2 to 8 weeks. Check TSH and FT4 every 4 to 6 weeks. In Graves, may go into remission after 1.5 years. Graves is autoimmune disease. The process subsides after some time. The autoantibodies are exhausted after 1 to 1.5 years. No more treatment can be there. Such patients, antithyroid treatment will be discontinued and just followed up every 6 months. 40% experience recurrence in 1 year, retreat then for 3 years. Initial treatment 1.5 years, 1 to 1.5 years. If they recur, treat for 3 years. Treatment is not lifelong. Graves seldom needs a knife. It is not a case for surgery. Graves means they should not touch. Graves disease does not require surgery because it is diffuse autoimmune inflammation, autoimmune excess of the thyroid. MNJ and toxic adenomas will not get cured by antithyroid. The symptoms will reduce, surgeon has to take. So the demarcation is very clear. Graves, mine. ATD and then MNG has thyroid. Okay. And you should not interchange. You should not start treating MNG for lifetime with your medicines. Some out of the hyperthyroid control, submit it. Graves, never refer to this. You yourself.
We do Graves if it's uncontrolled or not.
You do it. It's not indicated. It's not international recommendation. Graves is diffuse thyroid is there. Then why do you knock off the thyroid? You treat for what is treatable in 1.5 years with drugs. Why do you put them into surgery? Thyroid surgery has got its own risks. And hypothyroidism can occur, recurrent laryngeal damage, so many infection, bleeding and all that. Highly vascular organ. So thyroid surgery requires little expertise, not that hydrocele cutting or anything, isn't it? So you reserve it only when it's not responding probably after, say, 12 months or 18 months of antithyroid drug, then you are justified in control. Surgery. Not on the first one. For them, ATD is not the best, treat with radioiodine. So MNG and toxic nodular goiter, don't start with methimazole and thing. Put radioiodine treatment. and then submit it for surgery. So depending on the diagnosis, the treatment differs. In women who are not pregnant, radioiodine. In cases of toxic multinodular goiter and single toxic adenoma, you do it. In subacute thyroiditis, I don't require to do because it is going to be normal. In Graves, it is going to be only a diffuse thing. This is not remitting with ATD, then you can do a radioiodine. REI treatment is the best treatment for hyperthyroidism in adults. The effect is less rapid than the ATD or thyroidectomy. It is effective, safe, does not require hospitalization. Given orally as a single dose in capsule or liquid form, radioiodine. Very few adverse effects, as no other tissue absorbs the radioiodine. The advantage is this radioiodine is selectively absorbed by thyroid gland. There are very few side effects of the other outcomes. Now, how much I give for treatment? This is for treatment. I-123 is used for scintigraphy, that should not be used for treatment. I-131 has to be used. For diagnosis, I-123. I-131 for the treatment. 6 to 8 millicuries is the dose, only single dose. Goal is to make the patient hypothyroid and then supplement the thyroid. No effects such as thyroid cancer or other malignancies. Never given in children, pregnant and lactating women. Not recommended with patients with severe ophthalmopathy. Not advisable in chronic smoker. Now your surgical treatment. What is the surgery that is available? Subtotal thyroidectomy, total thyroidectomy, hemithyroidectomy with contralateral subtotal. ATD and RAA treatment are very efficacious and easy. So surgical treatment is reserved for multinodular goiter. They have two wonderful weapons in hand. The ATD is there for Graves, and for the MNG and other things we have. Radioiodine, surgery is required only when they are not responding. Severe hypothyroidism in children, pregnant women who cannot tolerate ATD. If at all I give ATD, only propylthiouracil I will give. Large goiters with severe ophthalmopathy, large MNCs with tracheal compression, dyspnea and pressure symptoms, and who require quick normalization of thyroid function. Suppose patient is having ischemic heart. This excess thyroxine is throwing a lot of stress on the. So we quickly have to bring him to normal thyroid function. So much so the heart ischemia can be saved. So it's like doing a treadmill test for it. If you have hyperthyroidism, heart rate is 130, 140, that means he's already every moment he's on treadmill. So you have to bring down very quick. So these are the few conditions. You start intervening with the thyroid. If you consider subtotal thyroidectomy, total thyroidectomy, hemithyroidectomy, contralateral. Okay. What is the surgeon doesn't take up immediately? You'll ask you prepare the patient and say, how do I prepare? ATD to reduce hyperfunction before surgery. Beta blockers to titrate the pulse to 80. SSKI saturated solution of Lugol's iodine. It is available of concentrated solution. So 1 to 2 drops, not one full bottle. 1 to 2 drops of Lugol's iodine or saturated solution dissolved in a full glass of water, BID for 14 days. This every surgeon wants to do this because it's a hypervascular structure. Bleeding will be terrific. And so you have to prepare the patient with Lugol's iodine. This will reduce the thyroid blood flow, thereby reduce the perioperative bleeding. Recurrent laryngeal damage is a problem. Hypoparathyroidism may be a complication. Inadvertently, you will remove parathyroid also. Then he will go into hypocalcemia and hypoparathyroid features also. So these are the preoperative preparation. So what do? Give ATD, methimazole, or propylthiouracil for 2 weeks. Give beta blockers, give Lugol's iodine, reduce the blood flow, then ask the surgeon to operate. So what is the dietary advice? People will ask immediately what diet I should take. Every time you ask about disease, patients will ask about diet. Because they are more interested to eat. We are born to eat. So eat to live or live to eat. It's a natural question. Anyway, so avoid iodized salt and see. It's very difficult. If I ask them to buy non-iodized salt, very difficult in the market because almost all the salt is iodized. Okay. Then how do I get iodized, non-iodized salt? Take the salt, make it into a solution, heat it up, and then use that decoction of that salty decoction. And that becomes very little iodine. Once you heat it, the iodines get separated from the salt, and it will remain in the solute, the solvent you take out, and that will be salty only. That they can put it in their sambar or. So if you cannot remove if you cannot get an iodized salt, you can non-iodized, you can do that. These are practical tips. Excess iodine in some cases maybe excess iodine may be there. Expectorant medications, X-ray contrast dyes, CV tablets, health food supplements. These should be avoided because the iodine interferes with or complicates the management of both ATD and RAI treatment. Why do I want to avoid iodine? Of course, excess iodine is going to produce more hormone. I don't want to happen. Not only that, interferes with my antithyroid drugs and the radioiodine. Now, this is the summary slide. There are 4. The red one is the Graves. Next one is MNG. Next one is the single solid adenoma. So the SAT. TSA, single toxic adenoma, SAT is the last. Now, age, Graves 20 to 40, toxic adenoma more than 50, single adenoma 35 to 50, acute thyroiditis, subacute thyroiditis, any age it can have. Percentage, 60%, 20%, 5%, 15%. Enlargement, diffuse enlargement, lumpy bumpy thyroid, single nodule, no enlargement. Pain, none. Pressure symptoms may be there in multinodular, single adenoma, none. Acute thyroiditis, painful thyroid. Radioiodine, very much increased in case of Graves. Toxic multinodular, increase. Single nodule, only that particular nodule is increased. Subacute thyroiditis, it on the other hand may be decreased because it is an overflow of the hormone. Treatment, ATD for 18 months, no surgery to stop. Toxic multinodular, either RAI or surgery. Single adenoma, RAI, ATD, rarely surgery. And acute thyroiditis, no antithyroid drugs, steroids and NSAID. This one table is sufficient to understand what all we have talked. TSH is markedly low, FT4 is elevated. That means that is the primary hyperthyroidism. What is thyrotoxicosis fictitia? Excessive intake of thyroxine causing thyrotoxicosis. Patients, sometimes primarily psychiatric disorder, they will have 100 milligrams tablets of thyroxine. They will take 10 tablets. Thyrotoxic, very much more sweating, all this, they'll come. Thyrotoxicosis fictitia. Ask the patient, did you take any tablet? No, don't even have tablets. They will deny that. Primarily, a psychiatric disorder may lead to wrong diagnosis and wrong treatment. Looking at the hyperthyroidism, people will put them on all sorts of drugs, including radioiodine, subject them for scans and all that. So clinically, thyrotoxicosis, but eye signs are absent. Because how eye signs will come? This is not Graves, no. High dose of thyroxine lead to thyroid suppression. You see, TSH is very low because exogenous thyroid they have taken. This causes shrinkage of the thyroid gland, stop thyroxine, and give symptom relief drugs like beta blockers. They will improve in no time. This may be a short notes for you, thyrotoxicosis fictitia. Okay. Now, so this algorithm for thyroid nodule, we will do in a separate class. Now we will take it up later. Now we will close here. I will ask you a few questions. You answer the questions. We will see how much you have understood. Okay.